Hi, I'm Dr. Meghan Davis, and I am the lead of the Hamilton Family Health Team Green Initiative. This video is made in April of 2022, and it summarizes the clean air and respiratory excellence component of the Green Initiative. The Green Initiative offers a series of webinars through modules 1 to 8 on how to reduce office waste and office emissions, clean air respiratory excellence, as we will overview today, plant-rich diets, nature time, disease prevention with cancer screening and smoking cessation, as well as choosing wisely. First, let's put things into context. The Lancet Commission on Climate Change has identified it as both the greatest global health threat and opportunity of the 21st century. And healthcare is responsible for almost 5% of all of Canada's emissions. So let's jump into the Clean Air Respiratory Excellence project. Everything in this video is also on our infographic, which is on our website. When we look at the relative environmental impact of all of our work in primary care, we can see that it is important to really consider aspects of prescribing metered dose inhalers, as they represent the second largest category of our primary care carbon footprint, as seen with this UK data, more than travel, the footprint of our buildings, and our equipment. We tend to automatically think of what we see, which is our garbage, and we think recycling is what we should do. But our visible waste is not really the problem. It is the tip of the iceberg in terms of greenhouse gas emissions, because emissions from healthcare consumables are up to 90% of the product's emissions happen before we ever use them. So if we recycle our garbage, we are only modifying the 10% of this. So we can't recycle our way out of this. And under the surface, there are some more powerful things that primary care excels at that we can do so much more. I want to acknowledge Dr. Andrew McNeil, a surgeon from British Columbia, with the idea behind this infographic. And I would like to emphasize that when we start to review metered dose inhalers, their carbon footprint, with the goal of low carbon care that is good for the planet, we will find many opportunities to improve our patient care, which is of course our fundamental goal. It is not a choice between health and the environment. It's not a competition. We will not detract from patient care. They are not competing priorities. We found a wonderful synergy to offer both excellent healthcare and also to reduce the environmental impact and costs. We started creating evidence-based knowledge translation tools and piloting changes in puffer prescribing with patients in March of 2021 at the pilot site, which is my practice, with Best Care David and pharmacist Mark. And we are ready to share what has worked. This is a multidisciplinary project. Respiratory therapists, pharmacists, physicians, QI, and project management have all been involved. And I've been so fortunate to have Tia Gajowski as our project manager, who created this slide deck with me. Reducing metered dose inhaler prescribing in healthcare when clinically appropriate is an established movement already. For example, the recent PBSG module from August of 2021, with the guideline changes around metered dose inhaler prescribing that also considers the environmental impact, and the Dalla Lana School of Public Health Center for Sustainable Health Systems has a community practice around metered dose inhaler prescribing and a national initiative through Cascades. We organized this project into opportunities for high quality care, as patient care always comes first. We considered diagnosis, asthma treatment updates, and information around puffer techniques. Then we explored the carbon footprint of different types of puffers and developed an action plan, including tools and tips from the pilot site. Okay, first, diagnosis. This quote is from Choosing Wisely, telling us that we should not be prescribing long-term puffers for COPD or asthma unless we have done spirometry. Canadian studies have shown that we don't do this. 44% of Canadians diagnosed with asthma and 67% with COPD diagnosis have never had spirometry. Now, the risk for patients is side effects from unnecessary medications, potential missed alternative diagnoses, unnecessary medication costs, and the belief that they have a chronic illness. And of course, the risk for the planet is an increased carbon footprint. How should asthma be diagnosed? Through spirometry with reversibility testing using a short-acting beta agonist, and if needed, a methacholine challenge has a high sensitivity, so it virtually excludes the asthma diagnosis. And how should we confirm COPD? Again, spirometry is required for a definitive diagnosis, and it should show a post-bronchodilator FEV to FVC ratio of less than 70%. I think I am guilty of sometimes unnecessarily prescribing puffers for persistent coughs. I find it helpful to be able to tell patients and myself how long viral coughs actually last, as we all underestimate the typical duration. Adults expect their viral cough to last under a week, when it actually lasts on average just under 3 weeks, and I think this might be even longer with COVID. Same for kids, with the average cough lasting 2 weeks, but up to 3 weeks, and there is no evidence to use Ventolin or bronchodilator because it did not help reduce the cough duration. Okay, next up is high quality care, and we're going to talk about prescribing inhalers for asthma. We are focused on asthma as there are recent guideline shifts that enable high quality, low carbon care in asthma. The GINA guidelines now recommend we do not use short-acting beta agonists, SABAs, like salbutamol, aka Ventolin, by itself for asthma. We should be always also using inhaled corticosteroids. When we use SABAs only on their own, it does provide short-term relief, but it does not protect patients from severe exacerbations, and in fact, increases the risk of those exacerbations. And those with apparently mild asthma are still at risk of severe exacerbations, emergency room visits, and death. Taking just salbutamol and then ending up with asthma exacerbations is then a risk for even more exacerbations, the need for acute care, loss of lung function, and death. And there are many studies that show that those with apparently mild asthma and those that use a lot of SABA have risk of severe exacerbations, emergency rooms, and death. Some studies show that frequent SABA use also causes rebound airway hyperresponsiveness, decreased bronchoprotection, decreased bronchodilatory response, increased allergic response, and eosinophilic inflammation. So these guidelines say we should avoid mono-SABA therapy, not using Ventolin or salbutamol on its own. According to the 2021 Sabina studies, the use of more than 2 SABA inhalers per year, regardless of additional maintenance or controller medication like inhaled corticosteroids, is correlated with an increased exacerbation and hospitalization incidence and mortality. And we should use corticosteroids as they are associated with a decreased risk of death, as shown in this study. The problem is that even if I know this, and so I prescribe inhaled corticosteroids to be used, for example, BID, the evidence shows that less than half of my patients fill that prescription, and even fewer, 38% in some studies, self-report that they use that steroid puffer. We see that patients are more able to manage their puffer prescriptions when they have only one puffer that has both their beta agonist and their inhaled corticosteroid. So studies show that patients are more compliant with only one puffer and that they always usually need an inhaled corticosteroid. And in fact, this is what the trials tell us and is the basis for this Canadian Thoracic Society 2021 recommendation that for asthma over age 12, one option is a combo puffer for asthma for PRN use as a reliever and the same puffer BID dose as maintenance in the form of the combination of formoterol, which has both long and short-acting beta agonist effects, combined with the steroid budesonide. This is called an anti-inflammatory reliever strategy. These are the GINA, or Global Initiative for Asthma Guidelines, which recommends low-dose inhaled corticosteroid formoterol as an option for initial symptom reliever and a stepwise approach with regular daily use plus reliever. The Canadian Thoracic Guidelines also suggest that for mild or very mild asthma that PRN SABA may not be enough, and these patients often also need an inhaled corticosteroid. They also suggest budesonide formoterol as one option, especially for patients who find compliance with multiple daily puffers difficult. 2 Canadian puffers have formoterol inhaled corticosteroid combo, the long and short-acting beta agonist. This white, red, dry powdered inhaler on the left is Symbicort, and the meter-dose inhaler on the right, which is Zenhale. Thus far, for use as a reliever or PRN or rescue, there are only clinical trials for Symbicort, not Zenhale yet. And as we will explore shortly, Symbicort is a dry powdered inhaler and has a significantly smaller carbon footprint than a meter-dose inhaler such as Zenhale. One consideration with dry powder inhalers like Symbicort is that they contain lactose, which isn't a problem for lactose intolerance, but can be for lactose anaphylaxis. I did hear that a generic Symbicort is coming in the fall of 2022. Let's move to inhaler technique because it doesn't matter what we prescribe if it isn't going into the lungs. There are lots of studies with up to 70% incorrect use and even more with children and older adults. So even if we've made the right diagnosis and we've picked the right puffer, if patients are not getting the medication, studies show that they have more hospitalization, end up on oral steroids, have poor disease control and quality of life. After learning this, whenever I prescribe puffers, I mention how important technique is. Here's a quick refresher on inhaler techniques. With the dry powdered inhaler, load the dose, have a quick, forceful inhale with your lips sealed around the device, keeping the inhaler upright, and hold for 10 seconds. It can be less than that for children. For a meter dose inhaler, you need to shake the inhaler every time before you actuate it. You have a slow inhale, taking 4 or 5 seconds while holding the inhaler or the spacer to your lips and actuating the medication. Hold for 10 seconds. Again, it can be less in adults. You should wait at least 30 seconds before the next actuation and ideally use a spacer device, for example, an aero chamber. Many studies show that dry powder inhalers are easier to use with less errors, partly because when you inhale, it activates the medication, so you don't have to sync activation and inhalation like you do with meter dose inhalers. Dry powder inhalers also have dose counters, which many meter dose inhalers do not. Short, effective videos on this can be found on the Canadian Lung Association website and on Asthma UK, and of course, our community pharmacists are super helpful. Okay, so we've looked at 3 areas of high-quality patient care: diagnosis and prescribing and puffer technique. All 3 of these, in fact, are also low-carbon care. If we use more spirometry to diagnose, we follow the guidelines and use Symbicort, and we ensure inhaler techniques, we will end up providing better lung care, and also we will end up prescribing less meter dose inhalers. And meter dose inhalers have a large carbon footprint that is the equivalent of a 290 kilometers worth of car emissions per 100 doses or 200 puffs. This is due to the liquefied gas propellant that is a hydrofluorocarbon that acts as a potent greenhouse gas. This data is from the UK and it's based on their transportation data, and puffer types is likely a bit of an overestimate for the Canadian numbers, but it's still significant. The propellant most commonly used in meter dose inhalers, hydrofluorocarbons, has 1,300 times the global warming potential of carbon dioxide, and a propellant less commonly used but still present has a 3,300 times the global warming potential of carbon dioxide. We didn't always use hydrofluorocarbons. Many of us remember in the past, meter dose inhalers used a different propellant, a chlorofluorocarbon, as a primary gas propellant. But these CFCs were banned under the 1987 Montreal Protocol as they possessed significant ozone depleting properties. So it got changed to the hydrofluorocarbon. The propellant is different, but there is still a large environmental burden. Almost all of the impact of meter dose inhaler puffers over their life cycle are from the propellants, much more so than the waste from the plastic. So meter dose inhalers have a high impact, and here are some of them. There's Advair, Helvesco, Atrovent, Flovent, Q-Bar, Ventolin, and Zenhale. And dry powder inhalers that do not have the propellant have a much smaller impact. There are a lot of dry powder inhaler devices out there, and here are some of them. The format of the inhaler matters for carbon footprint, with dry powder inhalers and soft mist having a much smaller footprint than meter dose inhalers. According to Health Canada's document, almost 900,000 salbutamol inhalers are distributed each month across Canada. That's a huge carbon footprint and a huge opportunity for better patient care now that we know we shouldn't usually be using just salbutamol and that overuse is concerning. Asthma is very common. The diagnosis is almost 10% of Canadians, so hence the huge number of puffers. With the common diagnosis and the large carbon footprint, meter dose inhaler prescribing is a significant portion of all of healthcare's carbon footprint. We did an audit within the Hamilton Family Health Team on a practice size of 2,000, and we found 330 patients with metered dose inhalers on their active med list. Assuming 1 inhaler per patient per year, which is likely an underestimate, the metered dose inhaler prescribing from the practice was equivalent to driving across Canada almost 8 times. Each time we switch from 1 metered dose inhaler to a DPI, we reduced carbon. I find it easier to think in terms of carbon equivalents. So this switch of 1 MDI is the equivalent of the carbon sink of about 12 square meters of a Canadian forest. And in the studies doing just that, over 90% of patients stayed on their DPI, and almost half of them thought that the footprint of their inhaler is important to them. There are great opportunities for high quality, low carbon respiratory healthcare. So how can this be done amidst busy clinical days? Well, we've been piloting this since spring of 2021 in my practice and have some tools and ideas to share. First, patient preference and symptom control are prioritized, always when prescribing puffers. While carbon footprint is important, patients' health and preferences always come first. And sometimes metered dose inhalers are necessary. Here are some of the circumstances that we found. First, kids can't usually create the inspiratory velocity that is needed to activate a dry powder inhalers. So metered dose inhalers are useful for preschoolers. Similarly, for severe cases of COPD, patient preference is also important. So let's look at cost. Although DPIs are often cited as being more expensive, one Canadian study found that over 50 years of mild asthma medication use, savings were on average almost $10,000 per patient when using as-needed budesonide formoterol DPI in comparison with an inhaled corticosteroid therapy plus an as-needed short-acting beta agonist. This price difference is due to the decrease in acute exacerbations from SABA overuse and consequent emergency room visits, hospitalization, and systemic corticosteroid costs. Also, when looking at the cost per day between these two therapeutic schemes, the combined as-needed budesonide formoterol costs 34 cents less per day compared with low-dose inhaled corticosteroid and as-needed SABA because of the decreased number of inhalations needed for asthma control. So although there is an initial sticker shock in the long term because less medications are often needed, overall, studies have shown that the ICS-LABA combo to be less expensive. However, this must always be balanced with the patient's willingness to pay a more expensive fee upfront, which may not be possible for them. If a SABA is needed, consider a prescription of the lower carbon footprint Ventolin Discus, which is not covered by ODB, or Briconel Turbihaler, which is covered, or a metered dose inhaler. If it's needed, there is a generic salbutamol called Aeromir. Aeromir is considered a low charge inhaler, which means it uses less propellant. It does cost 84 cents more per inhaler, so the patient has to agree to take on that cost. If you choose to prescribe Aeromir, you have to write no substitutions on the prescription. We are working with community pharmacists to ensure that there is a stock of these. All of this information is on our infographic, and I'd like to acknowledge that this slide was adapted from the Dalai Lama School of Public Health Center for Sustainable Health Systems. If a metered dose inhaler is needed, ensure proper technique and suggest the usage of a spacer. Encourage the patients to return their old inhalers to the pharmacy for incineration, which has a smaller footprint than landfill. Currently, there are no recycling programs active in Canada, although I believe that the UK has some. This device, the Turbihaler trainer whistle, can help determine if dry powder inhalers are appropriate based on inspiratory force. If you can make it whistle when breathing in, a DPI should be considered. These whistles are in the sample pack that you can order for your office from our website. There is also the in-check device that can be purchased for use in high-risk COPD patients. Let's talk about team members who can help with this initiative. I have David from Best Care in my office, who has, along with pharmacist Mark, done the majority of much of the patient-facing care within this initiative. Many of my COPD patients have had at least one appointment. So if you have the office space, I highly recommend them. They do offer in-house spirometry, and they are available to all primary care funding models. This is the pathway we ended up with my office. When I got a puffer prescription request from the pharmacy, I usually dispensed one with no repeats. I wrote a note on the prescription that we wanted to speak to the patient. I also sent the patient an email, and I have put this template with an ocean that you're welcome to use or adapt for yourself called puffer prescription. And then they ended up having an appointment with either myself, with our registered nurses, with the pharmacist, or with Best Care. Here is how my asthma prescribing has changed. I used to use Flovent for maintenance, BID, and PRN Ventolin. And now I follow the guidelines and I prescribe usually only one puffer, which is the combination budesonide formoterol. And I use this both PRN, if that's all that's needed, or if they need maintenance, BID, and both. Some as a reliever PRN and some as maintenance. I write the maximum puffs per day on the prescription of 8. I use the Oscar EMR and I have this saved as a favorite, which I think you can do in most EMRs. When talking to patients, we always emphasize the care perspective. I did have one that was already on a meter-dose inhaler with an inhaled corticosteroid and formoterol PRN, i.e. Zenhale, and I asked her if she wanted to lower her carbon footprint, and she said yes. We found patients to be receptive. We used our registry to document when a COPD or asthma diagnosis was confirmed, so we don't have to keep searching for spirometry in their chart. The ODB code for Symbicort is 330. Again, these details are all in our infographic. We always try to go over technique. We did find that some patients didn't want to stop their puffers, even with a negative methacholine challenge, which really did rule out their asthma. I collected data over the last 9 months. So on average, I had about 1 to 2 patients per month that we talked to about their puffers. We followed always a shared decision-making model, so no puffer switches without the discussion. Patients were identified predominantly from puffer renewals, a few from symptoms. 2/3 were asthmatic, a third had COPD. We deprescribed 12 meter-dose inhalers. We had some asthma and COPD de-diagnosing, which was very meaningful to me and goes back to the first thing we talked about today. First thing I spoke about today, which is diagnosis with spirometry is key. 80% of patients stayed on their meter-dose inhaler, just like the literature shows. The reasons for not switching were that they had a weak inspiratory flow, that their respirologist told them to take this puffer, and some had true dairy allergies. We were able to consistently demonstrate puffer technique, and we had a great patient satisfaction demonstration through a survey we gave out. Based on our experience, we built some tools that might help. Here is our patient-facing poster that you can order from our website. It says, does your inhaler look like this? If you're over age 12, it might be time for a change. Let's talk. And here is a full picture of the puffer alternative guide that we adapted from the work done in Toronto. And if you want to measure your meter-dose inhaler prescribing for before and after snapshot, the fabulous QI group created audits for TELUS and Oscar to find all patients who were prescribed a meter-dose inhaler in the last 2 years. Our meter-dose inhaler education kits are available locally in Hamilton to order from our website, and they contain our inhaler poster, the Lung Association poster, medication information, demo inhalers, some DPI whistles, and contact information to order more. We have an infographic that has all of the project summary on it. It also has some templates you can use for patient and internal communication, including an Ocean e-form to email patients with links to how to use their puffers. And last but likely should be first, I must mention smoking cessation, which just happens to also be low carbon and high quality healthcare, as our smoking cessation infographic on our website explores in detail. We have a whole poster series, not just on meter-dose inhalers, that you can order from our website to help sites educate them and also for our patients to see. We send out a regular Green Corner newsletter to roll out the initiatives, to share success stories, and to make fun challenges. And everything we have built is organized on the Hamilton Family Health Team Green website page, including contact information. So thanks for listening to this video on our Clean Air Respiratory Excellence project. Please get in touch. Here is our email and our website. Bye now.